This is our last musculoskeletal conditions lecture on juvenile rheumatoid arthritis, or JRA. Juvenile rheumatoid arthritis affects 300,000 children in the United States. And the definition is it's characterized by joint inflammation and stiffness, and the symptoms last more than 6 weeks. And it affects children less than or equal to 16 years old in order to categorize them as juvenile rheumatoid arthritis. And usually the symptoms for JRA begin between 2 and 4 years of age, and it's known to be more common in girls. The etiology is it is considered an autoimmune disease, which is when white blood cells lose the ability to tell the difference between healthy cells or bacteria. And so in JRA, the immune system actually releases chemicals that damage those healthy tissues and cause that inflammation and pain. They don't really have an exact cause. There's speculation, of course, about genetics, and if some kids are more genetically predisposed to having it. And they also are speculating that it may be triggered by certain environmental factors, such as certain viruses prenatally or neonatally, those sorts of things. So the symptoms can be very subtle or obvious. Again, there's different types of JRA or categories of JRA, and so some can be more severe than others, and we'll talk about those different areas. Usually the first sign or early warning sign is just a child limping. You may have a child complaining of a sore wrist, a sore fingers or knees. And again, looking at ages between 2 and 4 years of age, they may not be able to just tell an adult, you know, my knee hurts, right? But you may see them shaking out their hands or rubbing their wrist or rubbing their knees or sort of limping and favoring one side or over the next. It is categorized by joint swelling, and sometimes their little joints can get so swollen and enlarged and even warm to the touch. And so that's kind of a significant sign also of arthritis. They may experience stiffness in the neck, hips, or many other joints as well. Sometimes with JRA, you'll see strange rashes, and overall systemic fever. Again, those rashes can be brought on by fever. Swelling of lymph nodes. And so when you think about it, you have a child who's limping, right, or rubbing something that's something sore. You have maybe swollen lymph nodes and a fever. A parent may be thinking it's just a normal childhood illness, or maybe my child was outside playing and they twisted their ankle, or they just slept wrong on their hips, or something like that. And so again, those symptoms are lasting more than 6 weeks. JRA is categorized by flare-ups and remissions. And so some kids will have flare-ups where they'll have really painful swollen joints, and they have a significant fever, and then all of their symptoms will disappear and they'll be in remission. Those flare-ups can come and go at any given time also. In severe cases, growth is affected by joints, and so they may grow too fast or they may grow too slow, which would cause maybe one limb shorter or longer than the other, which you sometimes see that with gait, right, with one leg longer than another, which throws off their core, which throws off their hips and lower back, and those sorts of things. Eye inflammation is something that is in a certain type of JRA that we'll talk about later. And that inflammation, if not treated or if not caught, can actually lead to blindness. And so it's something that, if JRA is something that is a contender for a diagnosis, that's something that they'd want to investigate. They make the diagnosis of JRA by doing a thorough medical history and a thorough examination. And so They may do x-rays. They may do certain blood tests to rule out other related conditions, like do they have a fracture? Obviously, they take an x-ray of the bone. Why is this child limping? Um, they would look at blood tests to see if there's any infections or elevated cell counts, red blood cells, white blood cells, platelets, those sorts of things. Which could tell them if there's an infection. Lyme disease, lupus, cancer also is sort of a contender because you have that fever, you have that fatigue, you have some pain. And so all of those other diagnoses should be ruled out. Other tests may be a complete blood count or CBC, where they're looking at all the cellular components of the blood, looking for abnormalities in these cells. Erythrocyte sedimentation rate checks how rapidly red blood cells settle to the bottom of a test tube when it goes through that spinning cycle. And so the rate often increases in people, or that blood cell settles to the bottom quicker in people where there's inflammation occurring in the body. ANA is called anti-nuclear antibody. And so like any antibodies, your immune system sends out these antibodies to sort of protect itself or fight off things, right? And so they can test for anti-nuclear antibodies in the blood, which would give an idea if it's an autoimmune disease. And so if a child is positive for anti-nuclear antibodies, it can be used to predict children who are likely to have that eye disease with their JRA. Bone marrow examinations allow doctors to look at where the blood is actually formed in the bone marrows, and would rule out your leukemias, those kinds of things. Bone scans could also be done to detect changes in bones and joints, which would look at the cause of any unexplained bone or joint pain. So the different types of JRA, pauciarticular is a type, and it's categorized by where it affects 4 or fewer joints. They have very few or no systemic manifestations, so they may not experience a fever, they may not have a rash, but they still may have some joint swelling and pain, stiffness. It usually affects girls under the age of 8 years old, and typically the knees, hips, ankles and elbows are the most affected, and ironically, with pauciarticular, it only affects the joints on maybe the left side of the body or the right side of the body. Iridocyclitis is actually the chronic eye inflammation that can lead to blindness, so that anti-nuclear antibody or ANA blood test that looks at autoimmunity can be used to predict whether or not a child would have iridocyclitis. Having this type of JRA, there's a good prognosis because fewer joints are affected, and it's noted that pauciarticular JRA is more likely to go into early remission and not even come back. So there's hope for this type. Polyarticular affects more girls than boys. Again, the onset can occur at any age, but instead of only 4 joints, 5 or more joints are affected. It affects small joints of the hands, as well as the knees, hips, ankles, feet, and even neck. And here, a child may present with a low-grade temperature or fever. They may be listless, have malaise or complain of fatigue. The arthritis on the joints affects the body symmetrically, so on both sides of the body. And a lot of times they can do a blood test called the rheumatoid factor or RF factor, and I know some adults who have had this tested as well. And if they test positive for this RF antibody, typically it's going to be a more severe case. The prognosis is better if they have a negative RF factor, but again, if they have a positive RF factor, there's a higher possibility of the arthritis being disabling. Systemic JRA affects both boys and girls equally, and the onset can occur at any age. Again, if it's categorized as juvenile rheumatoid arthritis, the child should be 16 years or younger, and it affects the entire body. This, however, is the least common form, and it's characterized by a very high fever. During the fever, the child may be very, very sick, nausea, they may appear pale. This is where they may have those red pale spots all over, maybe on the chest and the thighs, which may come and go. They also may develop a rash. This fever typically doesn't go away. As a result, the spleen, liver, and lymph nodes may also become enlarged. And over time, many of the body's joints are affected. Over the entire body, and notable swelling, pain, stiffness is there. You may also see kids with a very high white blood count, and they may have a low red blood count, which would signify anemia. And so the prognosis, 50% of kiddos develop severe chronic arthritis and have recurrent systemic manifestations such as inflammation, infections, and there's even an incidence of leukemias that are associated with this type of systemic JRA as well. So the treatment in OT and even some of the medical treatment, so some of the other professionals that they may see, maybe PT as well, OT, maybe there's nursing involved, home health care, those kinds of things. The first and foremost thing is to control that inflammation, which would help relieve pain. And so if there's inflammation there, they say using cryotherapy or cold packs is supposed to help because that causes vasoconstriction, right? And so it closes off the blood vessels or tighten the blood vessels, which would sort of act as a pump and sort of push that fluid out of that system or out of that area. If we reduce inflammation, it's also going to provide pain relief. Personally, I've seen and I've used a combination of heat and cold, and I avoid really extreme temperatures, especially when somebody's having a flare-up. They say when somebody's having a flare-up that the use of heat is actually should not be used because heat vasodilates your blood vessels, which would cause further inflammation. And so if you have an area of your body that's further inflamed, adding heat to that area may be contraindicated. So with arthritis, though, having an extreme temperature can be painful. It can hurt, whether it be really, really warm or really, really cold temperatures. So a lot of times what I've done with adults and with kiddos that are having a flare-up is using what's called a contrast bath. And so maybe starting off in lukewarm water, maybe doing some active range of motion in that lukewarm water, Again, if it's anything warmer, it may cause some achiness or some pain. And kids tend to be, the kids I've worked with tended to be a little more sensitive to hot and cold too. So, um, again, maybe a lukewarm bath. It kind of helps um, relieve some of the joint stiffness by having them do some of the active range of motion under the water. It loosens things up. And then I put them in cool water. And so what's happening is the warm water loosens up their joints. It vasodilates their blood vessels. So yes, they're kind of at risk for further swelling. That's why we dip them then into the cool water. So then those blood vessels sort of vasoconstrict, and then you're still working on that gentle active range of motion, maybe some passive range of motion, very, very gentle with them. You're working on some of those kinds of things, and then you go back into the warm water. And so going back and forth like that is known to really control that inflammation. Because it vasodilates and then it vasoconstricts, and then it vasodilates and then it vasoconstricts. And so every time it vasodilates and constricts, it's pumping some of that fluid out. When you do active range of motion, those kinds of things, it also is contracting those muscles in that area, which also helps sort of vasodilate, vasoconstrict those blood vessels, which further act as a pump. Contrast baths, there's various types of programs and stuff that have them. Again, for pediatric practice, I tended to use less extreme temperatures than I maybe would for an adult. For adults, I've also used paraffin and hot packs, followed up by active range of motion. Again, with the heat, you're vasodilating those blood vessels, but then with the exercise and the active range of motion, the heat is kind of relieving some of that stiffness, so they're able to move more. And if they're able to move more, that actual muscle contraction alleviates what swelling would be there for heat also. And so again, something you have to really practice with, get an eye for, and use your clinical reasoning. Again, with occupational therapy, we may want to prevent further joint damage, and so doing joint protection techniques, educating parents on joint protection techniques, using larger joints if you're able to. So instead of gripping a jar with your fingertips, are you able to sort of straighten your fingers, use your shoulder to press down on the top of a jar, and sort of abduct your shoulder so that you're not using the DIP joints and the smaller joints of your hand, which could further be damaging. There's also excuse me, there's also lots of adaptive equipment that are out there to open jars, to help with dressing fasteners, those kinds of things. Anything to maximize those functional abilities. And so increasing somebody's independence with cutting food, with a knife and a fork. So maybe you're building up the handles on the knife and the fork so they're easier to hang on to, and you don't have to squeeze as hard, putting more pressure on those PIP and DIP joints of your hand. So anything we can do to either adapt, modify, prevent, and then using those modalities, using exercise within reason, those kinds of things. For some kids too, I've used Binnick hand splints, which are neoprene. One of the girls I worked with that had JRA had some wrist pain, and as a result, she didn't want to use her fingers. And we don't know, she was really young, so we don't know if it was affecting her maybe MCP joints, those kinds of joints or not. I know her little wrists were red and swollen, and she liked to kind of hang on to her thumb, which isn't very functional. And so we gave her a soft neoprene thumb spica splint that we ordered for her through the Binnick hand company or splint company. And actually the compression around her wrist and her hand was very comforting to her, and it held her thumb out into opposition, and we saw her using her hand more and more. And again, with that neoprene around her wrist, it seemed to decrease some of her pain. Obviously, with medical management, they may be prescribed NSAIDs, so non-steroidal anti-inflammatory drugs such as aspirin, ibuprofen, naproxen. They also may be prescribed corticosteroids such as prednisone. Prednisone is used to manage like that overwhelming inflammatory or systemic illnesses. And now when you're on corticosteroids, usually the doctors didn't like to have people on them for long term because there can be some long-term side effects with those. Disease-modifying anti-rheumatic drugs such as methotrexate are also used on occasion. And so they may be on a variety of different drugs. I know one of the kiddos I worked with was prescribed methotrexate, and it just really wreaked havoc with her stomach. A lot of side effects, and so it was a combination of how long do we leave her on corticosteroids, when do we add methotrexate, let's give her a break off the corticosteroids, okay, she seems to be doing better, let's wean the methotrexate off, and then she'd have another flare-up, and then they put the methotrexate back on. And so it was very frustrating for the family, and they were really managing a lot of nausea and vomiting, trying to weigh the pros and cons with her inflammatory state and pain and those sorts of things with these hard-hitting drugs. As I've mentioned before, with OT, we may be looking at increasing somebody's independence wherever they're at developmentally. If it's dressing fasteners, I know with this little girl, as she progressed, we worked on buttons and zippers and those sorts of things. Providing adaptive equipment to sort of protect those joints if applicable. We gave her built-up eating utensils. We gave her built-up writing grips, those kinds of things. You may be educating on conserving energy. If they're having fever and malaise and fatigue, you have to kind of weigh that out with, okay, how much do you want to push them versus how much do you want them to conserve their energy so they can take a shower or they can go to school or preschool, those kinds of things. Range of motion is important, and with arthritis, you just have to really be careful. Do you use modalities to help decrease pain and stiffness and then work on your active range of motion? I was always very conservative and very gentle with range of motion because I didn't want to do further joint damage. And also splinting, resting hand splint or any finger braces or those sorts of things to sort of prevent those joints from further damage and give them more stability. Like I mentioned, using the soft Dabinic neoprene hand splints were really helpful for this little girl. Physical therapy may also be involved. They may also work on kind of strengthening overall endurance, range of motion, those kinds of things. The little girl I worked with, not only were her wrists and hands affected, but her ankles and feet were really affected. And so I know physical therapy did some modalities on her ankles. They did some range of motion on her lower extremities. They worked on trying to do strength and endurance and those sorts of things. Strengthening exercises are actually contraindicated during that inflammatory phase. And so anything with resistance, so your heavy therapies, those sorts of things can be contraindicated. And so but your active range of motion or your light resistance may actually alleviate some pain and some inflammation if it's done very gently. And it's something that you have to weigh and use your clinical reasoning, and something you have to try and monitor. Like, okay, so we're working on, joint mobility. And so we did a contrast bath, right, with warm water, cool water, warm water, cool water. We ended with warm water. Uh, and then we did some active range of motion by, maybe digging in some really light therapy, those sorts of things. And then I'm following up with the parent, with the caregiver. Did you notice an increase in swelling after this session? Did you notice a decrease in pain or an increase in pain? And so, I'm following up on that, because again, with some resistance, it may decrease some of that inflammation, but with too much resistance, it's going to increase pain and increase inflammation. Sometimes looking at seating and positioning is really important too, just to maintain their functional range of motion, those sorts of things. Maybe seating can be monitored to help reduce fatigue, prevent pressure on certain joints, those kinds of things. And so whether they're in a wheelchair, whether they're in a chair at school, or preschool or daycare, or at the dining room table, those kinds of things you just want to be aware of. Again, using proper ergonomics when seating would be the most useful for their joints. Complementary and alternative medicine may also play a part, whether they be supplements, special diets. There's certain foods that are known to increase inflammation or decrease inflammation. So certainly, you may have some clients that are trying some of those types of alternative treatments also. The one little girl I worked with, that I'm thinking of, who had the most severe case that I've seen, her family also did acupuncture, and they really felt that acupuncture helped. And so that's something that they continue to do through her flare-ups and those sorts of things. And so, personally, I never ruled anything out. I thought, hey, if you are noticing difference in this, you go right ahead. It's not going to do any harm, and if you feel it's helping, that's great. So just know that there are alternative medicines and complementary medicines out there as well. So just to kind of take you through a case, I also had a young boy who had JRA, and so and he was affected. It just kind of came out of the blue. And he was a little bit older, and in baseball and those sorts of things. And then he came down with an acute phase of polyarticular JRA. The main problem that we saw was decreased fine motor skills, which caused dependence with dressing. And so some strategies that we sort of implemented was just making simple recommendations for the child to wear pullover shirts or elastic pants, so he didn't have to do the snaps, which when you line up the snap and you press and pinch really hard, you're putting a lot of pressure on your DIP, and even PIP joints. And so being able to just wear a pullover shirt using your joints, your larger joints such as your shoulders, instead of your fingertips to complete the buttons or the snaps, those kinds of things. Sometimes, even if shoulders are affected, it may be hard to use a pullover shirt, and so maybe adapting shirts with Velcro, and so they just have to line up the Velcro and use the palm of their hand to press. Teaching the child to close snaps with his palms, and so he didn't want to adapt his shirt with Velcro because it made him look different. And so we were able to have him line up the snaps and press his palms together using zipper pulls, those kinds of things. So again, just looking at adaptations of dressing, we also used some tube insulation that you can get at like a Farm and Fleet store, or like a Menards, a Lowe's, Home Depot, those kinds of stores. and you can cut them at certain lengths, and they're foam, and so you can use that foam to put over a pencil, you can use that foam to put over a spoon, a knife, which just gives the grip a little bit bigger surface area for your hand to grip, so you're putting less pressure again on those smaller hand joints. Prognosis varies in such a wide range, again depending on the different type of JRA it is. The largest percentage of children with polyarticular JRA recover completely within 1 to 2 years. And so they go into remission, and it just magically disappears, and they never have issues with it again. This young man that I worked with, he went on to play high school baseball. I think he went on to college baseball, and he never had any lasting effects whatsoever. The young girl I worked with went into remission, and as far as I know, she had a more severe case with more joints affected and more fevers and those sorts of things, higher fevers, and she went into remission. But hers, it was about 2 years, and it affected her, fine motor coordination and independence with self-care skills, because when she was younger, she just never engaged in some of those activities because she couldn't, because of pain and those sorts of things. And so we had her in therapy, I want to say, for 2, maybe 3 years. When she went into kindergarten, we were able to discharge her, and she's never looked back since. So she's doing very good. They say about 15% of all children with JRA do have permanent disabilities, though, whether they be joint contractures or abnormalities, bone deformities, those sorts of things. And so it's something to keep in mind. Just sort of a case story on your own if you're looking for a case. Samantha is a 7-year-old who enjoys playing outside, dancing, being with her family. She recently started to complain of pain in her knees, ankles, and elbows. She often holds her arms in that flex position because sometimes when kids are experiencing pain, they automatically go into that fetal position. And so that flexed, guarded position for her seemed to be more comfortable. You're known that she's in the acute phases of JRA, so she's having a flare-up, which is those beginning stages, and she saw the doctor and was diagnosed with JRA. And so just some questions to consider. What type of JRA do you think Samantha has? What are your concerns regarding her flexed sort of protective posturing, primarily in her upper extremities? Do you think Samantha will recover from this type of JRA? What types of activities would you avoid during this acute phase of JRA? Okay, so just kind of some questions for you to kind of go through and consider. Related video, there's a nice article or a nice informative video on like the medical perspective of JRA, and then there's an individual story about JRA. So I hope this video has less pauses than the other video. Let's go ahead and see how it works. Thank you so much.